Hello. Good evening all. At the outset, I would like to thank organizer of the IDCM, very nicely organized cardiometabolic conference. Now, being Barodian, I now left up with two moral responsibilities at the moment. Number one, I have to welcome all the delegates, all the faculties, and all the guests to the very wonderful Sanskari Nagari of Gujarat in India. Second, I am the last man standing before you and your dinner, so I would like to be as quick as possible, right? So as in introductions are nicely mentioned, that is a very important topic. Before going into topic, can I ask that how many faculties and delegates here, they are actually dealing with the indoor hyperglycemia management? Can you raise the hand so that I can have? So yeah, it's close to 50% of, right? So that will be good to discuss the thing. So almost 10 days back when I got the call from organizer about this particular topic, what first thing I did was, I have just surveyed around 100 consultants. Out of those 100, around 70% were doing practice for less than 5 years, and rest were doing more than 5 years. So what I asked them to see that how many of them were actually aware of the guidelines of inpatient hyperglycemia management. Those physicians who were not dealing with the ICU patient, out of those physicians, close to 65% were actually aware of the guidelines, but unfortunately around 36 out of those 100s were not aware of the guideline. In ICU physician or critical care physician, as we say, 88% were aware, so that is quite a good number. But whether you were aware, whether you were not aware, how many were actually following the guidelines? It was little disheartening to see that around 50% were following. Rest 50% were very much happy with the sliding scale still. So that was the disheartening part, right? But those who were following, the 50% who were following the guidelines, out of those 50%, 78% felt that we still have difficulty in implementing. Though I have knowledge, I have everything in part, but I am still not able to implement properly the way I want to, right? So this is the analysis that I started with, right? So we'll go through this agenda, we'll see what is the burden of this particular problem. We'll quickly go through the guidelines and discuss a couple of cases where you can have a little bit of more insight that how you can implement this guideline, and then we'll finally end up with take-off message, right? Now this slide you all will come across over and over again that in 2021 Atlas of IDF, close to 90 million adult diabetes patient is estimated to be in Southeast Asia region. Out of this 90 million patient, 75 million is there in India. So that makes around 1 in 11 adults are having type 2 diabetes, right? But not only that, what are worrisome part that close to 4.3 crores of these estimated population, those who are having diabetes, they don't actually know that they are having diabetes, right? And 7 or 8 out of these 10 patients, they are actually not having their HbA1c, their fasting, their prandial at the controlled level, right? And even today, more than 1.1 million deaths is attributed to directly or indirectly to the diabetes annually, right? So these are very some statistics that we should know. Now, what is the economic impact? Annually, a diabetic patient, whatever economic burden is there to that patient or to his family, out of those burden, 35% is for hospitalization, right? So another very important statistic to remember. And those patients who are getting indoor, out of those patients, 40% of patients are having sugar, which is not normal. Either it is hypo or hyperglycemia, but the sugars are not normal. And another important point, that those who are having sugar and getting admitted, 70 to 75% of those patients are actually critical care illness patient or cardiovascular patient, right? So they automatically put themselves into a risk of bother, right? Now, this is a proven fact in multiple studies that hyperglycemia and the mortality, as we can see in this particular study, the patient with normoglycemia, the mortality was just around 1.7%, but almost doubles if your patient is having sugar, the mortality is 3%, and newly discovered hyperglycemia, the mortality is even high. The prevalence of hyperglycemia in critically ill patient, as you can see that close to 50% of patients actually admitted into the ICU, they are having high sugars, right? 22% are already recognized diabetic patient, 5 to 6% are unrecognized diabetes person, and just 20% are having normal sugar, those who are admitted in ICU. And needless to say that if your patient is having hyperglycemia, getting into the critical care setting, the mortality is way high as compared to normal glycemia patient, right? Now these were about hyperglycemia. What about hypoglycemia? You will agree to my point that if you put a target of 150 milligram per deciliter in your indoor patient and you are checking the sugars, in your medical officer checks sugars 3, 4, 5 times in day and the sugar comes around 180, 190, none of the relative will come to you and ask, sir, sugar 180 ho gaya. But if a single episode of 60 sugar or 50 sugar, every system will be blasted, right? The relative is panic, the patient is panic, your medical officer is panic, even probably you are panic, right? So hypoglycemia is an even bigger issue many a times, right? It has been estimated that in intensive control arm, as many of senior colleagues will agree to this point, that probably 2-3 decades back where there were so many studies being done for intensive glucose control in inpatient hyperglycemia management. So in intensive control arm, there were close to 20 to 40% of hypoglycemia event. Less than 70 milligram per deciliter, in ICU setting 10%, and in non-ICU setting 3 to 4% prevalence was there. Severe hypoglycemia was around 2% in ICU and 8% in ward, right? It was more common in type 1 diabetes than type 2 diabetes, okay? Overall, total incidence of inpatient hypoglycemia because of treatment, that is iatrogenic, was close to 3 to 29%, right? So not only that, hypoglycemia associated autonomic dysfunction, right? That is another autonomic failure. It's another important point that if you don't monitor this patient and if they have autonomic dysfunction, they are not going to tell you, sir, I am having hypo symptoms, right? So monitoring is the key. That is the main important part to avoid the mistakes, right? Now in this meta-analysis, as you can clearly see, if you have hypoglycemia and the glucose variation is high, then the length of stay as well as 90-day mortality both increases significantly, okay? So keeping this background in mind, we quickly go through the guidelines what the various national and international body recommend to keep your blood sugar values in your inpatient setting, right? So before going to the guideline, these 3 lines are very, very important. Just knowing the cutoff of sugar will not serve the purpose, right? You need to train your medical and paramedical staff. This is the most important point, right? The insulin monitoring protocol and insulin protocol, be it a subcutaneous basal bolus therapy or IV infusion therapy, if your staff is not trained properly and they are not experienced properly, then believe me, whatever amount of knowledge you have, you will find it difficult to implement. So this is the most important part before going into the guideline. So the one aspect of doing this, that you can put a poster or some material on the floor where they are working to give them the insight into the monitoring and the insulin protocol, right? Besides this, they should know the profile of the insulin. When will be the onset of their action, what is the peak action, and when the action will wane off, how to give insulin, of course, they will be the basic things, and insulin storage, right? So you need to make sure that whatever order you give to your medical officer or nursing staff, this all order are followed, right? Because we'll see the examples earlier that you may find that in a patient who is in fasting state, they come to you in the morning hours, you have planned for a particular surgery, the blood sugar is 120, but he or she was on the basal insulin of 30 units, so you need to deliver at least 70% of that basal insulin, even the patient is NBM. So if your instructions are not clear, your medical officer or your nursing staff will definitely be hesitating to give that 20 or 24 units of insulin to that patient who is NBM and who is posted for surgery, right? So you have to make sure that all the orders are followed perfectly, right? So this is the guideline, very simple. Now it has been becoming very increasingly clear that there is no need to intensively control almost all patients, be it a critical care setting or non-critical care setting, right? Now in the ICU, the treatment threshold, you will only start insulin if the blood sugar is more than 180 and the target sugar is around 140 to 180, right? So almost all society gives us the same idea, right? you can always keep this particular image in your mind. Any patient, the blood sugar less than 110 is not recommended, except in those neurocritical ICU where it is been said if you can keep the blood sugar level of 110 without hypoglycemia, then it is good. Otherwise, you should be happy to 100 to 140 in those patients as well. The recommended sugar 140 to 180, right? And again, more than 180 is not recommended, but almost all practical purpose, keeping the hemodynamic status of your ICU patient, keeping the glucose variability that you can see in the various glucometer, anything less than 200 should solve your purpose, right? So this is the basic idea that you need to keep in mind, right? There are many insulin protocols available, so we are not going into that detail, right? But this is just to enumerate those who don't know that you start if you are giving IV insulin. Remember, in ICU patient, critically illness patient, you have to give IV infusion, specifically when these patients are not taking orally or they are on some inotropes or any other life-saving measures, right? Yeah. If somebody can ask that your myocardial infarction patient, after thrombolysis, he is still in the ICU for a day or two in monitor, and he is taking perfectly all the meals, then you can put that patient on basal bolus therapy. In this patient, you may not give insulin infusion, but otherwise, all patients should qualify for IV infusion therapy, right? And once you start the IV infusion, you need to monitor at least an hourly, right? If you set a target, your target should be achieved every hourly. If you cannot achieve less than 30 milligram of deciliter of blood sugar, then you need to increase the infusion. If you can achieve it, then you can increase the monitoring hours, and you need to have an equilibrium in your insulin infusion and your blood sugar level. If your blood sugar level start falling, you can always give IV glucose infusion, but you must not stop insulin infusion unless there is hypoglycemia. That is the main important part you should be considering, right? In non-critical setting, again, very easy targets, right? 140 to 180, it is recommended by American Diabetes Association. Endocrine Society, almost same targets, right? Joint British Diabetes Societies, they were little more relaxed that if anything less than 200 should do in non-critical setting, right? So this is the point, and this is very, very important, the sliding scale, right? So as those 50% of physicians, even what I have analyzed, they are still using sliding scale. Now, sliding scale is absolutely outdated. For last 2 or 3 decades, all the standard textbooks are mentioning the word that sliding scale is obsolete. Please don't use it. Why we should not use it? Just to give a brief idea, as you can see on the left side, right side of your slide, that it is a roller coaster effect of insulin, right? You are allowing your blood sugar to get increased, and then you act. And once the blood sugar become normal, probably your patient is taking some calories, you are not covering those calories with the insulin. So you are again allowing the blood sugar to get increased, and these things are going on. So it is not the recommendation, right? So you should never ever use sliding scale except on certain situations. So it is a non-physiological way with retrospective reaction to the blood glucose levels, right? So poorer glycemic control with increased risk of hypoglycemia as well as hyperglycemia, right? It promotes glucose roller coaster, and we certainly do not want, because glycemic variability, as we have discussed, that it has a very deleterious effect on the length of stay as well as 90-day mortality. It is not at all individualized. You are not considering what calorie your patient is taking, what is the insulin resistance your patient is having, what are his previous data, right? What is his baseline cardiac or renal status? It is not individualized. It's a reactive approach, right? So sliding scale is absolutely outdated. You must not use in those patients who are taking enough calories in an indoor patient, right? Now, there are many studies which have proven that basal bolus therapy, if you put your indoor patient on basal bolus therapy, probably in next 1 or 2 days, your patient will always be controlled. The chances of your target, which has been set by you, is achieved by basal bolus therapy is close to 70% as against to sliding scale, which is close to just 30%, right? So the sliding scale is obsolete now. Please make note of this. Right? What is then regimen? Many a times this particular topics is discussed in so many local, regional and national level. Still many a times many younger physicians are asking, okay, sir, if we don't use sliding scale, then how we use basal bolus therapy? So for those patients, we are discussing little in detail that basal bolus therapy, there are essentially three components, a basal insulin, a bolus or mealtime insulin, and a correctional insulin, right? So generally what you do, that you decide a target dose of your patient, the target insulin total daily dose. Then in that target dose, you divide 50% into the basal dose, rest 50% is divided again into the, according to the meal of the patient. And if, it was our meal? Okay, yes, sorry. And if your pre-meal target is not achieved, then you need to add correctional insulin, right? So this is very simple thing. If you start following, you will find that it can be done by your nursing staff as well. Even your help is not needed, right? So this is how you calculate the target dose and correctional dose you give, right? Now basal insulin, there are 3 generations of basal insulin available now: NPH, Glargine 100 unit, international unit, and Glargine 300 and Degludec, right? So traditionally speaking, those who are using Degludec and Glargine 300 unit, they will agree that there is some benefit in the incidence of the hypoglycemia, specifically nocturnal hypoglycemia, and they are true 24-hour basal insulins, right? So if you can use Glargine 300 unit or Degludec 100 unit, then it is good. If you cannot use because of certain economic issue, then Glargine 100 unit will also serve your purpose, right? There is not much difference in that. Some specific conditions like preoperative, as I just discussed, in case of major surgery, you need to give basal dose even if your patient is NBM, right? But what you need to do is you need to give at least, you need to reduce the dose at least 20 to 30% of the current dose, right? This is important point you need to consider, okay? And if you are using Glargine 300 unit or Degludec, then they are the longer acting basal insulin. The half-life is approximately 46 hours for Degludec and 34 hours for Glargine. So you need to reduce the dose probably 2 or 3 days before the planned surgery. But for Glargine 100 unit, you can reduce either if you are taking evening dose, then a day prior to surgery, or if you are giving a morning dose, then even day of surgery, you can reduce the dose. But the point is, you still have to give the basal dose. Just 2 minutes, right? Another special condition, GBM and labor condition. Again, the recommendations are there. If you are, your GDM patient goes into the normal labor, you should keep blood sugar in between 100 to 126, right? If needed, if particular patient is not able to keep in this particular range, then you can either use insulin in high case, or you may need to give IV dextrose, right? But if an operative delivery is planned, say cesarean section or something like that, then you may release the target little bit. 100 or 150 targets should be fine in those patients, but because of general anesthesia, because of physiology of parturition, there is many fluid changes going on, many physiological changes occur immediately. So you need to monitor very robustly, sometimes hourly or sometimes half-hourly during cesarean section. That is the important point you need to consider. And postpartum, 2 things you need to see, that immediately if a true GDM patient, the insulin requirement goes very low, right? So most of the times the GDM true patient postpartum may not need insulin, but you need to consider that if you have given an insulin, you need to tell the pediatrician or neonatologist who is attending the neonate to check for sugar of neonates, right? Again, steroid-induced hyperglycemia, basal bolus therapy will do. Another concept of correctional insulin, which is developed by none other than our own doctor, Dr. Rom Lokhani and their colleagues, that you need to give an additional correctional insulin depending about the glycemic profile of the glucocorticoids used over and above of the standard basal therapy, right? So this is a very nice paper they have published probably 4 or 5 years back, that if you are using hydrocortisone, you may give additional regular insulin. If you are using methylprednisolone and prednisolone, you may give NPH, or if you are using dexamethasone, you can use Glargine, right? So this is another important point you can keep in your mind. Now quickly, last 2 minutes, the case is, as I discussed that, suppose this patient of 50-year female, this has been post for cholecystectomy. Suppose she is having HbA1c of 6.9, fasting of 119, so she is absolutely controlled, and she is NBM from 12 a.m. prior to the surgery. So suppose she is having the same sugar with all 4 regimen, then how you will proceed the next day morning by this regimen only. Suppose she is on mixed-start 30-70, 20 unit before breakfast and 15 unit before dinner with OHA, right? Then what insulin you will give on next day? You will reduce the morning dose of mixed-start to 10. So you need to reduce morning dose in case of mixed-start. But it is for Indian patient. If you can put this patient on glargine from the prior evening to the surgery, that would have been better. But why glargine 18 is you need, as you can say, that the total dose of insulin was 35 units, so 70% of 35 unit would come around 23, 24 units, which was the basal unit, and you reduce further 20 to 30% before the surgery, then your glargine would come around 70 to 18 units, right? If this patient is on 24 unit of glargine, 100 international unit, it is straightforward. If you are giving morning dose or evening dose, reduce 20 to 30% and give, but you need to give. If it is on twice daily glargine, this is also many times we are still seeing this particular prescription, then glargine 8 unit in the evening prior to the surgery and 8 unit into the morning before surgery, right? And if your patient is on degludec 22 unit, what you need to give the next day? You need to give 18 unit 3 days prior to the surgery, so that you will be able to reduce the dose of degludec on the day of surgery, right? Another exhaustive case that I have put, but I just take permission of chairperson, this will take 2 minutes, right? So a 56-year female admitted for acute pancreatitis. She is in frank sepsis. She has come into the critical care setting, right? So as you can see, blood pressure is on lower side with very high total count. Some pre-renal azotemia is already there and very high amylase lipase. Blood sugar obviously high and HbA1c is also high, right? But your initial assessment suggests that you cannot put this patient on any oral diet or oral liquid, so you are putting this patient on NBM, right? So biggest fear in the ICU, even if the patient is NBM and it is clearly been suggested with such a high level of sugar and high level of HbA1c, you need to put this patient on IV insulin infusion. So this is what you need to do. The 327 of blood sugar, you divide by 100, it comes around 3.27. The nearest point is 3, so you start with 3 units of IV bolus, you start with 3 units of IV infusion per hour, then you check per hour sugar. If sugars are not getting at least 10% less than the baseline sugar, then you need increase 10% of your dose. If the sugars are reducing, you continue same till you achieve your target. Once your target is achieved, you need to reduce the dose, and you need to come even to 0.5, 0.2, 1 unit of insulin, and you try to avoid hypoglycemia. If your targets are achieved and sugars are getting in lower side, you add dextrose, but don't stop infusion unless your patient has started taking orally, right? This is the most important thing you need to see, right? So suppose in a day or two, the patient's pain is relieved and you are putting after 2 or 3 days into the soft diet, then you put this patient on basal bolus therapy, right? So total daily dose according to the weight should come around 28 units. You divide 14 into the basal, rest 14 into the bolus therapy. Then 4 times in a day pre-meal sugar, 1 bedtime sugar. Your targets are pre-meal sugar around 140. You start with this particular insulin within 2 or 3 days. You can titrate this patient to 14 unit, 4, 6, 6 unit, and you can discharge the patient. But what happens, probably in 8-10 days, this patient again comes with the upper GI symptoms, which are very, very severe. Patient look toxic. You evaluate the patient, the CT scan suggestive of walled-off pancreatic necrosis. Again, she is in need of antibiotics and the inotropes, right? The blood sugar is again high. So even this time, you have to put this patient of IV insulin, right? And some intervention, probably your gastrosurgeon or gastrophysician will plan to drain that walled-off pancreatic necrosis, be it an open surgery, be it percutaneous drainage or whatever it may be, but probably for 3-4 days, your patient is not going to eat anything per oral, right? So you need to continue IV infusion allowing dextrose during this particular time where he or she is not taking any calories. Another very important point, right? Suppose probably after post-op 3 days, she is becoming little stable, and your ICU physician and your gastrophysician puts this patient on TPN, right? So TPN, again, you are delivering a calorie. You need to continue the IV infusion, right? So after intervention on 7 or 8 day, you are starting again on RT feeding, right? So this RT feeding is probably a situation where you add a basal insulin, and along with this particular thing, you have to put a sliding scale start, because you cannot count RT feeds calorie and you can give the mealtime insulin, right? So this is probably the only indication where along with basal insulin, you will give sliding scale. Remember this, because most of the ICU patients, they are not giving basal insulin, they are just giving sliding scale. Probably 3 or 4 ICU where I visit, I have seen this particular scenario. So this is an important thing you should keep in mind, right? So once again this patient start taking orally after further 7-8 days, you again put this patient on basal bolus therapy, right? And you can discharge. So this was a type of case when all the insulin protocols were followed, be it IV infusion, be it sliding scale, be it basal bolus therapy, correctional dose. So take home message, you should always try to follow the guideline-based insulin therapy for a given scenario, right? You need to avoid glycemic variability because hyperglycemia at one end will increase your complication associated with your surgery or infection, right? And 90-day mortality, again, hypoglycemia will have some deleterious effect. Monitoring is the key. If you cannot monitor, you can never give proper insulin, right? Set insulin and target sugar protocol of your own setum. Your hospital must have this type of protocol. It should be put on the every floor of your hospital. Your all medical officer, your nursing staff, your ICU physician, registrar must be very much experienced with this protocol, and training of internists is very important for successful management. With this, I'm going to stop here and will be happy to have any questions. Thank you very much.
Thank you, Dr. Unadkat, for such a detailed explanation and touching the main points, particularly the basal bolus regimen. Would like to invite some questions, if at all interested.
So I guess all are hungry and insulin has worked nicely.
Yeah.
Stop here, right?